Hi, everybody. A warm welcome to all of you from the International Academy of Clinical Hematology. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, in France. It is actually a little bit after 6 p.m. in Paris, 5 p.m. in London, noon in New York, I guess 6 p.m. in Wurzburg, Salamanca, Pamplona, and Lille, but also in the Canada, in Calgary, it should be around something 5 minutes or 4 minutes, 5 past 10 a.m. So it is a great pleasure to welcome all of you to this now, what has become a tradition, which is a post-ASCO, post-EHA roundtable discussion organized by the International Academy for Clinical Hematology. Thank you for being very loyal to this activity. And today's roundtable is going to be dedicated to immune therapy, namely bispecific antibodies, but also CAR T-cells. And similar to previous years, in every hematology big meeting now, you see new things when it comes to multiple myeloma. And this is really, I would say, not work in progress, but a revolution in progress. It is quite incredible to see the amount of novel data being presented, including in plenary sessions and late-breaking abstracts. And we're very proud that our distinguished faculty, Dr. Hira Mayan, Dr. Paula Rodriguez Otero, Dr. Kui Young, Dr. Nizar Baylis, Dr. Herman Ainsley, Dr. Thierry Facon, and last but not least, Dr. Joshua Richter. You noticed I just put them by alphabetical order. So nothing, all of them accepted to join us tonight for this roundtable discussion. So my first question to all of you, and please don't hesitate to jump in and to ask questions to each other, guys. And of course, I'd like to remind our audience that you can also send your questions using the chat box, and I'll do my best to share it with the panelists. So just whether at ASCO or EHA, and I know some of you did both of these meetings, but we had also the IMW Group Summit just immediately before EHA. What is your overall impression and the most striking results when it comes to bispecific antibodies? Who wants to start? Should we give it to the ladies first?
Yes.
Kui, I can see you're smiling and ready. Your microphone is open.
Oh, yes. Well, I can start. Yes. For me, the bispecific antibody treatment paradigm has entered combination therapy. So we have barely seen the completion and the final results of single agent bispecifics, but I think what's been striking in the last few weeks with the meetings has been the results presented with combinations. So talquetamab with daratumumab, which Dr. Baylis presented so eloquently, and also the combination of teclistamab with talquetamab presented by Dr. Mateus at EHA. And I think first of all, what is striking is that combinations are feasible, are tolerated and possible with these new agents. And secondly, they also afford the opportunity to increase response rates. Whether they increase durability remains to be seen, as to be honest, follow-up still remains very short, even for the single agents, and also especially for the combinations. The toxicities and safety is, of course, an issue, and maybe we'll get an opportunity to talk a little bit more about toxicities in combinations as well as the single agents.
Wonderful. Thank you, Kui. So before going to the bispecific, because indeed I had on my paper, I prepared a few questions, specific questions about bispecific. Actually, I want to hear from you and of course, maybe I'm a little bit biased because, for instance, I presented the update of the Magnetism 3 trial results, which is single agent elranatamab in relapsed refractory multiple myeloma. And I said the results were really impressive. But of course, maybe because I'm the presenter and I contributed, what are your thoughts about these results, about the update of the teclistamab data, the talquetamab data, like as a single agent? Because today, for instance, I think in many places across the globe, we do have two agents available, teclistamab and elranatamab, which is good news. What are your thoughts about these results?
The one thing that please, so sorry.
No. I think I've had my turn. So Josh.
The one thing that I love about this is that, you know, I've been doing this for a little long, that maybe not as long as some, but longer than others. And there was a time where we were talking about single agents. At least if you look at all of the novel agents in myeloma, pomalidomide, daratumumab, carfilzomib, the single agent or single agent plus dex in the heavily refractory patient, all of these at least achieved FDA approval in the US with overall response rates of 22 to 30%. And we were ecstatic about that as single agent. And now it is just so heartwarming. You come to meetings like this and we can, I'm sure, dive into the nitty gritty of the details, but every single agent bispecific has been around 60 to 80% overall response rate, which is just so wonderful and so enlightening. And I think is that exactly as Kui pointed out, this is the new wave. This is how we're going to approach this. So we'll probably subset out patients to the nth degree, but globally, patients are doing much better.
Yeah, I think that also, sorry.
Yes, Paula, please.
What we have, no, I think that also what we have seen in both in ASCO and EHA, both with the monotherapy, elranatamab and teclistamab, is the data with the less frequent schedule. So patients switching from a weekly to an every other week schedule. For sure, these analyses are always biased because they are centered in patients that did respond. But I think that the good news is that responses are sustained even when switching to a less intensive schedules. And we have also seen some let's say, impressions that also the safety profile, particularly in infections, did also improve slightly after the switch from a weekly to every other week. It's true that at the same time we were given IVIG to all patients, we were implemented other prophylactic measures, so it's difficult to know whether it was only by the switching to a weekly to an every other week, but I think that also this helps the field moving forward, because for sure safety is something that we need to take a look at it, and probably by using a less intensive schedule will be one way of improving the safety.
I can see Hira raising hand.
Yeah, I was just going to echo and say that, you know, the response rates are impressive, but it will be interesting to see over the next few years the delivery of bispecifics. So we are already starting to see some preliminary data with preemptive tocilizumab. We saw some of that data at ASH, and again, we saw that with teclistamab as well. Can we decrease the rates of upfront CRS? And again, changing that may allow us to, you know, give our therapy to more patients. And similarly, I think we'll see a lot with dosing over the next few years, because we've kind of really said that this is an efficacious regimen, but lots to play around with the dosing and the schedule that will hopefully make it a much more effective therapy for all subgroups of patients.
Herman.
Yeah, I think we all had the feeling that bispecifics are really changing the therapeutic armamentarium that we have for our patients. And we clearly see that these new agents are moving to earlier lines of therapy. But I think especially with the work that Nisa has done, we all realize that probably the way the bispecifics are used at the moment are not the optimal application. And I think everybody felt that probably some treatment-free intervals or longer time between the applications might actually improve the tolerability. And I think the infectious complications, especially with the BCMA targeting bispecific, I think there is a major difference between BCMA and GPRC5D targeting bispecifics. But if you just look at the BCMA targeting bispecifics, I think we now increasingly learn that we have to increase the interval between the applications. And I think the data that was presented, especially by the group from the Memorial Sloan Kettering Cancer Center, that they started to give it only every 2 weeks, then every 4 weeks, and that could actually reduce the rate of infections quite considerably without losing efficacy, I think is a very good indication that we have to change the mode of application. And I think some of the very new protocols that I've seen, it looks like now really some weeks on, some weeks off could also be an option for being effective with bispecific and still getting high efficacy, but much lower toxicity than we have observed in the past.
I fully agree with you, Herman, because indeed in the MAGNETISM-3 results, actually, among those patients who switched to every 15 days, actually 80% maintains a response and actually decreased the rate of infection by at least 10%, which means this is feasible. And my best guess outside of a protocol, we have a lot of examples of patients going into 3 weeks, 4 weeks, and still doing well. Maybe Nizar, any comment?
No, thank you, Mohammed. I fully agree with everything that my colleague said, and very important. The only point I will add is about the sequencing of this therapy also and the resistance mechanism. So as you said, we're very privileged now. We have variable bispecific antibody, teclistamab, elranatamab, linvolistamab from Regeneron looks also very promising. And the question really comes up now, how do we sequence this therapy? Can we retreat with a BCMA antibody or not after progressing on a BCMA antibody? Should we switch? And some emerging data starting to suggest, especially from data you presented, Mohammed, about retreating prior TCR exposed patient, whether CAR-T or ADC, but also there was data from the teclistamab about prior treatment. And was encouraging that even in those patients who previously treated with these class of drugs, they do see deep and durable responses, and especially when we do combination in the setting of combining whether with teclistamab with talquetamab or combining TAL with daratumumab. So yeah, very exciting time. Lots need to be learned, and I fully agree with Dr. Ainsley and here I said earlier, duration of therapy and can we have a treatment-free interval as well?
Wonderful, thank you. By the way, to all the audience sending questions, don't worry, I'm taking good note of them, and I will sneak them in the discussion just to have a nice flow of the discussion. Don't worry, I'm not ignoring the questions. Josh, what are your thoughts?
So I think something that Herman and Nizar brought up, which is really, it's not just critical for these drugs, but drug development and clinical trial design moving forward. We were all raised in the notion of find MTD and then move forward with MTD. And what we're really learning from all of these drugs globally, especially from an immune therapy standpoint, MTD should not be the goal for these therapies. And whether or not the truth is minimal effective dose, but it's more than just saturating receptors as much as a patient can tolerate. And I think it's very exciting to figure out, is the optimal issue to give for a period, stop, and then resume at the time of early PD, or start and stop? Either way, this is going to have to result in a change of all trial development in terms of the protocol from day one for this type of treatment.
Fully agree, and I must acknowledge here, because not everybody may be aware of this, but for instance, FDA initiated a program called the Optimus program, which is about trying to help companies to maybe better develop or optimize the dosage or the schedule of administration, because maybe this historical dogma of chemotherapy and maximum tolerated dose and dose effect may not be relevant to immune therapies. I see Paula raising hands.
Yeah, and I wanted to comment on the sequencing aspect, because one of the aspects that I liked the most was the TAL plus DARA combination that Nizar presented at EHA, both from a safety perspective, let's say, and also from an efficacy one. And it's important to know that close to almost close to 50% of the patients, or 40 something, were already previously exposed to BCMA-directed therapies, with 1/3 of the patients coming from bispecific antibodies. So for me, the question that I have now in my head is, okay, if you have a patient now, not today, because today we only have access to monotherapy, but in the future that eventually we may have access to combinations, monotherapy, even the combination of the two BCMA and GPRC5D, are you going to use them in combination because it seems like the data, it's a little bit better? Are you going to sequence and going to the sequence aspect? Personally, in my short experience, I don't have a lot of good experience coming from monotherapy to monotherapy, even changing the target. The responses are there, but duration of response is normally shorter than the first one. And I have typically, use the trials that I have with combinations for those patients that were progressing on monotherapy. And maybe this is something that, the data that Nizar show from TAL plus DARA, and also in the TEC-TAL, combinations. Maybe this is also one option for patients that progress from a bispecific coming into a combination. Particularly, I like the DARA idea because of the, rationale behind of depleting the Tregs and changing the immune environment in the tumor that, makes sense from let's say, a biological idea.
Excellent, thank you. My question to you, Thierry, now, and then I'll take your comment, Quy, because we have a nice comment from our colleague in Poland, Artur Jurchin. I have always problems pronouncing his name, but he's our friend. Hello, Artur. Is about, do you feel that based on the data we have, that we are ready, for instance, for fixed duration therapy, because we mentioned that we can decrease the frequency of administration? And my other question to you, Thierry, because you are like the Pope of the elderly treatment oh, I mean, you are the guy who developed first MPT, then you developed RD, then you developed DARA RD. I think we need to acknowledge and recognize those guys who were like pioneers like yourself. So the question, are we ready for a fixed duration with bispecific, and whether you feel comfortable using them in the elderly population?
Okay, I am the Pope of the elderly. I don't know exactly what it means, but let's say that's good.
Only positive things.
Okay, I think we will, that will be fixed duration anyway. I cannot imagine that will be continuous therapy. Okay, from my point of view, it does not make a lot of sense to say that a bispecific will be continuous therapy, and that could be even more true for so you may also say that the CAR-T, which is not this part, will provide a very good opportunity to do fixed duration therapy, but still, you will have to discontinue bispecific at a certain time point anyway. Then for the elderly, I would say that, as you said, we are now familiar with response rates 80 to 100%, so that's just fascinating in a way. And if you want to summarize, you could say that what has been reported at ASCO and EHA is basically Q2 week. It's every, so we move from Q week to every 2 weeks, but we already know that if you want to treat older patients, every 2 weeks is too much anyway. So you will have to go every 4 weeks, or you may want to go every 8 weeks. I don't know, but you will have to modulate these regimens in terms of schedule, in terms of treatment duration, and that could be very successful. But my perception is that if you try to give too much, in fact, you will that will be detrimental for some patients, and you may lose patients of infection or something like that. So many things remain to be done with bispecific, and so you have the discussion for the elderly, but you have also the discussion for frontline, because what we have today is basically for bispecifics in relapsed refractory myeloma. So one day these drugs will move up to first line, in combination with other drugs. And okay, that's another that's another 10 years of work basically, or something like that.
Okay, Kui, you wanted to comment on this, or maybe on
yes.
other?
So what relevant to what Thierry has been talking about using the bispecifics in older patients. I wanted to come back and touch on the issue of infections. So we have to remember that our trials were carried out during, and many of them ran through the period of the COVID pandemic. And even if we take away the COVID infections and COVID-related deaths, for sure, these patients were having quite a bumpy ride because many of the prophylactic measures that we started taking, like IVIG, only happens sometimes midway through a study, and it often happened also at the time when the frequency was dropped from weekly to bi-weekly. So it's quite difficult to tease out whether extending the treatment interval to bi-weekly really reduced the incidence of infections, or we were just using more IVIG and got more familiar with looking out for these infections. But in general, I do think that as we learn to explore different schedules and implementing more prophylaxis as well as monitoring policies, we will be able to overcome some of the risk of these infections and learn to give these agents with a more tolerable infectivity profile. I think, and the same with managing the side effects like the nail and skin and dysgeusia toxicity with the GPRC5D agents. I think that and even if when these are only grade 1 and 2, if they last for a long time, they can be really quite distressing and debilitating, particularly the loss of taste. But then again, with dropping frequency of administration of, for example, talquetamab, these side effects are all reversible. So I suspect the toxicity profile is a kind of work in progress for us. I guess the other point I wanted to bring up was the sequencing. I think I agree with everything Paula said about sequencing. I think that we are learning that actually patients will respond to one bispecific having failed a previous bispecific, and it may depend on many things. Perhaps that the duration between the two agents and the timing of the last dose of the bispecific. Maybe I think the change in target may not be quite so important as the host, the fitness of the immune fitness of the host and the ability to reactivate the T cells. But we have to have a word of caution, because I suspect that even with the good response rates in retreatment with a bispecific, perhaps the PFS might be a little bit shorter, as we saw in the, I think it was the elranatamab studies, where patients who were treated with a previous bispecific, although their response rate was 40 to 50%, the PFS was only 4.5 months compared to BCMA bispecific naive patients. So that's something to bear in mind and remember. I also have a comment on combos, but maybe we're talking about combos later.
Yes. So at this stage, because now the questions from the audience are accumulating, I think I have 20 questions. So I'll group some of the questions about sequencing because some questions are overlapping. And now, well, obviously CD38 as a target, it looks like everybody will receive it first. It's unlikely that we will give, but who knows, another target. We will use another target before. But now, assuming the patient are candidate for a bispecific, and we have 3 targets being tested, namely BCMA, with the availability of teclistamab and elranatamab. We do have talquetamab targeting GPRC5D, and we have cevostamab targeting actually FcRH5. But we should not ignore that there are also bispecific targeting CD38 and being tested in those patients who failed actually an anti-CD38. So here, my question, let's say, Herman, because you've been quiet for a few minutes. What would be the optimal sequencing? I would personally, when I was asked this question, I would say, well, I would rather hit in the heart of the malignant plasma cell with an anti-BCMA before going to the others. But what are your thoughts?
I completely agree with you. We have probably more experience with BCMA targeting bispecifics than with any other bispecifics targeting different surface molecules on the myeloma cell. And we know that the BCMA targeting bispecifics can really induce deep responses. I think we have to be aware that they are really inducing severe B-cell depletion, that they are associated with hypergammaglobulinemia, and probably the rate of infection is higher when compared with the other targets. But I think at the moment, I would definitely start off with a BCMA targeting bispecific. The next step, I think it could be either GPRC5D. I think it has the advantage that there is less B-cell depletion, less hypogammaglobulinemia. Also, the data show that the drug is associated with less infectious complications. We have the skin and the mucous membrane toxicity. We have the dysgeusia, which is can be a problem in some patients. But it's also a drug where we have some experience. And in addition, FcRH5, I think targeting cevostamab is also an interesting agent in second line. And it has been tested in quite a few patients that were failing BCMA targeting bispecific. The overall response rate seems to be slightly lower when compared to BCMA targeting or GPRC5D targeting bispecifics. But we always have to consider that most of the patients that received cevostamab were pre-treated with BCMA-directed T-cell engaging or T-cell directed immunotherapy. So that could also explain this. About the CD38, I'm a bit skeptical because CD38 is broadly expressed, and I would like to see the drug to have some more clinical experience with it. I know that there is a drug from Amgen that was not further developed. We don't really know why, but the rather broad expression of CD38 on non-hematopoietic cells for me could be a problem because of on-target off-tumor toxicities with CD38 targeting bispecifics. But that's
so, I'm glad, Herman, you mentioned this. And actually, we don't speak a lot about FcRH5. And I remember a few years ago, I saw, but maybe Nizar, you have also information about it, that, for instance, FcRH5 may be more expressed in those multiple myeloma with gain1q. So maybe we would have a sort of although I know we're lacking data, but that reminded me of this paper like 4 or 5 years ago. What do you think, Nizar, and what are your thoughts on the sequencing in general?
I fully agree with Herman. I mean, you said that Thierry is the Pope of the elderly. Herman is the Pope of immunotherapy in hematological malignancies. But slightly.
Well, you know, now these days, I think it was a unique feature that we can have 2 popes at some point, because there has been some, you know.
And one of them can be German.
And one of them can be. And by the way, I would like to thank all our German colleagues who really organized a wonderful event in Frankfurt, and we could have a flavor of the wonderful German hospitality. And in addition, they managed to bring the good weather, which is quite unique, actually. In Frankfurt.
Yeah, the only different spin I would put on what Herman said, I'm curious what he thinks about it. We don't know much about resistance to BCMA and resistance to GPRC5D. And the only concern I have about BCMA resistance, BCMA drives NF-κB signaling in myeloma. And luckily in CAR T-cell, very few patients have biallelic loss of BCMA. And in those patients, when we sequence them, we find definitely other gains, specifically multiple copy number, like 8, 9 copy number gain at the MYC locus. We saw CDKN2C loss. We see NF-κB pathway mutation. So the cells are acquiring additional gain to survive the biallelic BCMA loss. while GPRC5D, at least as far as we know, has no function, pro-survival function in myeloma. And from that context, if I given more data on GPRC5D long-term follow-up, I would rather use GPRC5D first, because I'm assuming, again, it needs to be proven that the emergence of resistant GPRC5D is going to be almost like a neutral effect on the myeloma survival, and they can rescue them with BCMA. Again, it's purely conceptual. I have no data to back up, except, like I said, BCMA biallelic loss drives other copy number gain to promote survival of the myeloma cells. And what you said, Muhammad, about FCR5 is correct, absolutely. Cancer Cell paper published several years ago now showed that 1Q gain has, because FCR5 is expressed on 1Q, have higher copy FCR5. Does it mean more response in this patient population? The data so far doesn't suggest that, but at least you can say 1Q gain is present, FCR5 is expressed, so I can use it in this population.
Excellent.
I like your idea about the sequencing between GPRC5D and BCMA. Yeah, I like that, because this is, I think, one of the big questions that we have all in mind, because before the data look from an efficacy perspective, look a little bit better for BCMA. So we were all thinking, okay, maybe because the duration PFS is better, maybe it's better to go first to BCMA. But yeah, you have made me think a little bit more further.
Wonderful. Josh, yes, please. Thierry.
No, just one point. It's of course we decided to do one part with bispecific, one part with CAR-T, but it's difficult because we have CAR-T BCMA and we have CAR-T GPRC5D as well. So for example, when we talk about this on-target off-tumor effects of talquetamab, so the dysgeusia, the skin, etc., that could be potentially better using a CAR-T GPRC5D, because this effect will be limited in time. So basically, you do the CAR-T GPRC5D, and that could do a good job with no prolonged dysgeusias possibly. So you have to, when you talk about sequencing, it's of course it's a bispecific sequencing, but it's a broader sequencing, having a CAR-T bispecific, and according to the target and according to the toxicity, you may have some benefit using more a CAR-T or more a bispecific.
Thank you, Thierry. Josh?
So, just to the CD38, so there have been two big ones. One was, as was pointed out, AMG 424, which didn't seem to cause more CRS before efficacy, and a company called Glenmark, now Ecnos. I actually had the pleasure of infusing the first dose of what was then GBR 1342 into a human, which was very exciting for me. So far, we've not seen any great efficacy with the CD38, CD3, and hints that once you start to get to therapeutic doses, you may end up seeing CRS before you see clinical benefit, but further patients are needed. The other question about sequencing, and although I think
so Josh, just to be fair about this bispecific, because we're participating in the same trial, I guess my understanding, we are still in the cohorts where we didn't reach yet a therapeutic dose.
Yes, so you're absolutely correct. You're absolutely correct. This is a concern I have based on other platforms of similar ilk, but you are absolutely correct. I apologize.
Okay, no, but my role is to moderate and to be fair with everybody, because I can assure you, when we say something, people will send me a message, an email saying, oh, you said this, that was unfair, etc. So we try to be, we're very compliant, we are very fair at the ISCH.
Absolutely. And the other question about sequencing, part of this is going, I think Kui pointed this out perfectly. Antigen loss is not the whole thing. It's more about the T cell fitness. That being said, I think that if we all had our druthers, we would probably switch. And what I mean by that is, there will be a time in the not too far distance where we have BCMA and GPRC bispecifics, but the GPRC carts are a bit further down the road. So to me, I saw a patient earlier in clinic today that ultimately I want to get to a CAR-T. If in 3 months they progress too quickly where I think I cannot get them a CAR-T, my inkling would be to give them talquetamab, knowing that down the road, my next approach at a CAR-T is going to be a BCMA-based one. So that might sway the sequencing for me a little.
Okay, Thank you, Josh. It looks like there's no consensus, but it's very good because all of these scenarios are plausible and have some scientific rationale. Qui.
Hi, on the subject of CD38 antibody, well, this is not a bispecific, but I thought I'd throw into the mix modakafusp, which is a CD38 targeting antibody bound to a modulated interferon, and it binds to a different epitope from DARA and ESA, I believe, so that it may not cross-react and may yield responses in patients who've become refractory to those two antibodies. So there is an opportunity, and of course, this is an antibody that doesn't rely on T-cell fitness, and has a different mechanism of action in activating immunological responses. But I also wanted to come back and ask Nizar on his interesting comment about patients failing failing BCMA targeted therapies who have acquired biallelic loss. So that probably tells us that these particular patients will do badly or have a poor outlook. Do you think it is possible that if these patients are then exposed to a non-BCMA targeting treatment that is effective, perhaps high dose, maybe alkylator therapy, effective against a rapidly proliferative clone, that we can then re-establish BCMA targeting sensitivity by reducing that subclone? Or do you is your take that these patients really have moved on from being responsive to immunotherapy approaches?
Yeah, these are all important questions. We don't have the answer. I mean, if you have biallelic loss, you're not going to respond. But I want to emphasize that we're talking copy number loss, not mutation. So because what's interesting, we have some data suggesting also, and it's going to hopefully come out soon in a manuscript, that mutation don't necessarily affect NF-kappa B signaling, meaning you can acquire mutation alters binding, but you still retain NF-kappa B signaling through April, which is fascinating. And the cells know how just to mutate the binding of the bispecific antibody, but retain the NF-kappa B signaling through April. Again, so it's a complicated story. What I said is purely conceptual. We need more data, but what we've seen in the handful of patients who had biallelic loss of BCMA, yes, they were very aggressive. Like the two at least I experienced post-CAR-T, they behave like almost like Burkitt lymphoma. Disease blew up everywhere, pleural effusion, lymph node. Well, it's quite, and it's not the case all the time, but at least the two I experienced with biallelic loss of BCMA, and one of them had the 9-copy number in a MYC locus, and the other one had multiple biallelic loss of CDK and 2C. So the cells were growing extremely rapidly because of that. And
so it's probably important for us to understand which patients have experienced a biallelic loss, but there isn't any one good, easy assay in the lab at the moment, is there, Nizar?
I mean, right now we do it by whole genome sequencing, but in the future we can conceive doing like small dedicated NGS for those BCMA, FcRL5, and so forth.
Or could we measure soluble BCMA in the blood? Do you think that would give us the answer?
Partly, yeah. Even there is some trick there, but we can talk about it at a different time.
Oh yes, I see.
One last comment about this topic from Herman, because then we will move to a couple of other topics.
No, I think what Lisa pointed out is extremely relevant. I think the likelihood of a patient to actually develop a failure to GPRC5D targeting bispecifics could be really higher than for BCMA targeting bispecifics. And we had the chance to really look into monoallelic loss. And when we looked at monoallelic loss of GPRC5D, we found it in relapse refractory multiple myeloma in about 15% of patients, but only 4% we had a BCMA, unilateral BCMA loss. So already from the basis, there is a higher likelihood to develop a biallelic loss. And I think what Lisa pointed out, that the function of GPRC5D is really not clear. Probably it has no function in myeloma biology, and therefore it's much more prone to get lost when compared to BCMA, which has clearly a biological function for the myeloma cell.
Okay, thank you very much.
Can I just quickly ask
Yes.
Herman a question on this? So Herman, would you conceive, for example, giving a GPRC5D CAR T up front and followed by BCMA bispecific maintenance? Because I agree with you that these patients will resist by losing GPRC5D very easily. They're going to emerge very quickly, but you then hit them with the BCMA bispecific.
I think that could be an interesting sequence to really be tested. Yeah. And I think with your data, it might be also relevant to obtain lymphocytes early and store them, not only for CAR T cells, but maybe if we want to reuse bispecific, that we have some kind of functional T lymphocytes in the freezer that we can kind of rebuild the immune system before we re-challenge it with bispecifics.
Fully agree.
Okay, thank you very much. Actually, here we have a lot of questions. I didn't initially, when I prepared this broadcast, wanted to raise this, but actually Josh in his introduction highlighted the issue of the response rate. And while historically we were quite happy having like 30%, 35% overall response rate in the relapse refractory setting, actually, believe it or not, I have a half a dozen of questions about MRD negativity after bispecific. And these guys have, you know, received a median of 5 or 6 prior lines of therapy, but also achieving CR. And by the way, it is true that in the MagnetisMM-3 trial, I think there was 35% more than CR in this population. And obviously, it's difficult to compare across trial because in one of the posters of teclistamab, it was like 40% plus. But on the other hand, one may say, well, you had 35% extramedullary disease in the elranatamab cohort versus 17% in the teclistamab cohort. I think we can spend the whole day and night trying to compare these numbers. What is really impressive, for instance, is really that while we usually aim 30% overall response rate, we have now CRs. And this is why the median PFS is not yet reached with actually elranatamab. With teclistamab, we do have something around in the more than stringent CR, a median of 27 months. So what do you think the goal is? Response and MRD negativity becoming a goal when using bispecific in the relapse refractory setting? Kui?
Yes, I suppose this might be a trick question because the answer must be yes. But
I don't know. People are very excited about it.
No. But I wanted to bring up the points that all our data on MRD are derived from regimens which have included our traditional and our up till now classes of agents, and I think MRD negativity might need to be interpreted slightly differently in the context of immunotherapies, because in immunotherapy, not only does MRD negativity reflect depth of response, but may also reflect the continued therapeutic pressure on the clone from immunological mechanisms and not so much from pharmacological drugs targeted at the tumor cell. And I think the importance of continued therapeutic pressure on the clone can be seen in CAR T and therapies that then stop, and there's no longer therapeutic pressure on the clone, and that's why MRD is not such a good predictor of long-term outcomes in CAR T therapy. But in the bispecifics, it is a good marker of the depth of response, but the continued pressure on the clone immunologically has a negative aspect in terms of exhaustion of the immune system. So the mechanism of therapeutic pressure is different. So MRD negativity, I think, should be interpreted differently. But regardless, I think it is from a simplistic point of view, it is a marker of the depth of response and therefore likely to be a marker of long-term disease-free outcomes.
I think, Hira, you wanted to say something?
Yeah, similarly, just, it's great to see those fantastic overall response rates and responses that are really quick and rapid, because these are patients that, are coming off 5-6 median lines of treatment with sometimes explosive disease, and to get a quick response is fantastic. And the follow-up, again, with longer experience, we're getting longer and longer follow-up, and hopefully we will have the durability of response. But right now, I would say getting those overall responses and seeing MRD negativity is fantastic.
Okay, so let me move now to another topic, and maybe I'll ask Thierry. While, of course, the development of any new agent starts with a relapse refractory setting, then we start to move into earlier lines of therapy. And here, one interesting question, actually, there are several questions about the combination of bispecifics today with the currently established treatment in earlier lines. And we have actually two comments, for instance, which I think are really relevant. For instance, using bispecific for consolidation after auto, but also, for instance, for a relatively short duration of maintenance, but also maybe in the non-transplant eligible patient, Thierry, where we know Daral index is a standard of care, to say, well, if I want to limit the use of Daral index, maybe I can induce them for a year with Daral index, and then hammer them with, I don't know, 6 months of bispecific. I mean, I'm trying to summarize a lot of these questions we have received. What do you think?
You may have so many possibilities, so that's totally open. So one scenario would be just to add or to replace. So you could say moving from the DRD, you may see elranatamab DRD, so the dex will be dropped anyway, but so this kind of 3-drug platform, you could replace. So you could say, I would like to use lenalidomide with a bispecific instead of lenalidomide with daratumumab, because I do believe that might be a little bit more effective. And you could move forward with a daratumumab in combination with a bispecific. So you have so many possibilities, and if you want to play this game, you could be even more provocative. You could say that many patients will do very well with DRD. So if you get started with DRD in standard risk patients, in fact, and if you get at least VGPR in 3 or 4 months, you will do very well. But the other patients may do less well. So if you cannot achieve a high quality response in the short time, if you are high risk with DRD, you may want to do a little bit better. So you have so many possible strategies. But in the elderly, I still believe that the ability to use one particular regimen in the long term is extremely important. And so, for example, back to the discussion on talquetamab, I think it's totally impossible to stay on talquetamab for a long period of time, because you will not stay for 2 years with dysgeusia. At least in France, you will not be able to do that. So
even when you have the best wines.
Exactly. Even yes, even more if you have the best one.
Especially if you have
Especially if you have the best one. So you have so toxicities, long-term tolerance will be key factors, and if you want to be very brief, if you can manage one bispecific with one dose of daratumumab given every 8 weeks, and if you can achieve a good safety and that will be good efficacy as well, that could be some kind of successful strategy. But you don't have to give too much of bispecific. You don't have to give it too frequently, probably. So we still have a lot of things to do on tolerance, and especially long-term tolerance, I would say.
No, I think we are fully aligned that at the end of the day, whether in the elderly or in the younger population, it's about this balance, and it's more and more important to pay attention to the safety and the quality of life. And here I'd like really to acknowledge the contribution of the patient, but also the advocacy groups, because I have access to the people who are attending, so I can see a few patients, but also a few representatives. So here you mentioned, Thierry, the elderly, frail patient, and where you would be very cautious about some side effects like with talquetamab. But let me ask, for instance, Paula, because we have this question from the audience, assuming you have here a patient with deletion 17p, where you know that unfortunately in terms of disease aggressiveness, you're not in a good scenario. So at time of relapse, what do you suggest, let's say first relapse for this patient? And assuming you have access to CAR-T, bispecific, BCMA, GPRC5D. From a theoretical point of view, and that brings us a little bit to the sequence, what would you choose? And then I'll move to the combinations.
Yeah, so if the patient is eligible for CAR-T and CAR-Ts are approved and available and everything is fantastic, I will opt for CAR-T. And I think that in the first relapse, the likelihood that you will have a good option to bridge the patient to CAR-T is very high, even if you are not going to get a deep response. Only, achieving a little bit of PR or something like that will be probably enough for them going to Third eventually, and Herman maybe comment on the CARTITUDE-4. If the patient is not eligible for CAR-T because of comorbidities or because CAR-T is not available in the country or not, whatever, yeah, so I think that probably a combination with bispecifics will be the best. But I think that coming to the point that Thierry was discussing before, combinations with BCMA bispecific can be tricky and can be risky. So I think that we need to be, smart enough to develop these drugs in the best way so that we get the best of the two worlds, the best of the combination and the best of the efficacy, not to, let's say, have problems with long-term or severe infections or other issues.
Just one comment on just one follow-up point. What has been said by Paula is very important. For example, if you say talquetamab will provide less infections, but you have this kind of atypical toxicities, BCMA will give possibly more infections, but you don't have dysgeusia anyway. But if you combine both, you may get 100% response. But then if you get at the same time a high rate of infections and dysgeusia for a long time, that will not be very successful. So when you combine, you get more efficacy, but you have to play the game with the best part of each drug anyway. And so that, okay, we have to do that, but it's not that easy anyway.
So this is really fabulous, Thierry, although we didn't prepare this together in advance. Actually, you're giving me a wonderful transition to our next topic, which is the combinations. And it looks like what you're telling us, and that was my impression from the colleagues after listening to these talks, because we had really lovely presentations about the combination of talquetamab and dara, but also teclistamab and talquetamab. And while definitely in terms of response, it was a sort of a wow effect.
Yes.
Because it's better, it's impossible to do more than 100%. So I personally, I think, asked one of the speakers, I wanted to know who is the single patient, because I think there was one patient who did not respond, because we may learn a lot from the single patient, actually. So, but on the other hand, there was a little bit like discomfort about the safety. I think we've seen half a dozen of deaths, 6 deaths in one of these combinations. So what, Nizar, you presented one of these studies. What are your thoughts? And then I'll ask the rest of the panel.
And again, I agree with Thierry and you, Mohammed, but we have to keep in mind these were population of unmet needs. The DARA-TALC population was mainly geared for patients who had DARA refractory, over 2/3, 75% if I'm exact, were CD38 refractory to the daratumumab. And same thing with the TALC teclistamab combination. This was geared for external biliary disease population that doesn't do well with individual bispecific antibodies. So with that in mind, I will note that surprisingly, and again, I'm surprised by the data, small number, read longer follow-up, the incidence of infection with the combination of talquetamab, dara, grade 3, grade 4, relatively low, only 25%. And I don't understand fully why. You can argue there's possibly 2 reasons: that talquetamab doesn't alter the B cell population, so you maintain your B cell producing antibodies. This is perhaps the reason, but also the idea that the combination led to deep responses. So you restore the good health immune background, and therefore you have better, lesser infections. The teclistamab data is concerning for the incidence of infection a bit. I mean, it's not much higher than the individual monotherapies, to be fair as well, the grade 3, grade 4. Would like to see that number nevertheless lower. But I'm excited about the response in the extramedullary disease population with that combination.
I think, Josh, you wanted to comment on this.
Yeah, so the redirect data that Nizar talked about that was presented by Yao Cohen and then Mary V. The EMD is clearly great, but I think to Terry's point, the long-term toxicity is complex, and ultimately, being a person who could use a little bit of dysgeusia, I like my cake and I want to eat it and have it too. I think in the upfront setting, we are very comfortable with this idea of induction and maintenance. And I think we need to consider embracing these concepts in the relapse setting as well. Combination of TEC and tau clearly is going to take these people with big, bulky disease. The EMD responses are amazing, but perhaps we need to kind of hit them hard and then settle into a more maintenance approach.
That's an excellent idea. And that actually, there was a question about this issue of the impact of the tumor load on the response to immune therapies. And I think this is a very hot topic, has been debated in the allogenic transplant setting since, I think, 4 or 5 decades. Who wanted to comment on this? I think I saw Herman. Herman, you raised your hand.
Yeah. Looking back to our old days when we did a lot of allogeneic stem cell transplantation, it was clearly the goal to get the patient in best remission before we actually use this kind of immunotherapy. And why should it be different? The less tumor cells we expose to immunotherapy, the less likely the patient is going to develop severe side effects, because obviously cytokine release syndrome and neurotoxicity are clearly less severe. But also, if you have a huge bulk of tumor cells, the likelihood that one of these tumor cells will kind of develop a resistance mechanism is much higher when compared to a patient who has a small tumor load. And so I think for efficacy, it makes a lot of sense to reduce the tumor load before you actually therapy.
Okay, excellent. I think that's clear. Kui?
Oh, I just wanted to pick up on Josh's point about the extramedullary disease. So I think that's always been one of the patient groups who have fared less well with the CAR T cells as well as with bispecific antibodies, and I think it's notable. I mean, we all saw the photograph of extramedullary FDG avid disease shrinking. I'm interested in that and what everybody else thought. Is that because the combination of the antibodies allows the T cells to traffic into extramedullary sites, whereas previously they couldn't do, or is it simply because of increase in targetable antigens? So of course we know that with BCMA there is in many patients there is a group of there will be subclones with very low BCMA expression, and perhaps these are the subclones with GFR-C5D expression that then get killed by the other those targeted T cells. But why would that get the T cells into extramedullary sites? And it's worth, of course, we have to wait to see whether the data are confirmed in larger series, but that is potentially one of the benefits of a combination such as this. And once we learn to manage with dosing and scheduling, combining the two, it could be one of our answers to handling extramedullary disease in the context of these immunotherapies.
Excellent. Nizar?
Yeah, well, I want to follow up what you raised and link it to exactly what Kui is saying. So you asked Mohammed, how does soluble BCMA or disease burden affect disease outcome? And what Kui is saying also, how come extramedullary disease respond better to the combination? I think they're in a way linked. So what we've seen with all the BCMA targeting trials, that higher soluble BCMA does lead to worse outcome. Higher disease burden, extramedullary disease does lead worse outcome. And the group from Janssen, very nice analysis looking at the high impact of soluble BCMA on response to teclistamab, and nicely show Cortez and colleagues show that the higher soluble BCMA have lower outcome. But then when also looked how does soluble BCMA correlate with extramedullary disease, patients with extramedullary disease also have much higher soluble BCMA. So I think going back to what you're asking, I have no, again, a lot of concept from me. I think the reason why teclistamab and talquetamab do work, because talquetamab works as a debulking agent, so I debulk, reduce soluble BCMA, and I allow teclistamab to be more effective. This is one possibility, using as a debulking of the soluble BCMA and teclistamab more effective. But your idea also about trafficking is interesting. So hopefully Janssen is doing those studies to biopsies those tumors to see does indeed combining both increase the trafficking of less exhausted T cell to the tumor bed itself. That will need to be proven. But going back to soluble BCMA, it was interesting data from this meeting and also at ASCO. And Josh, you probably have the best experience about this with linvolistamab, the Regeneron BCMA. I only saw it at EHA because I didn't attend ASCO. They showed very nice data of response based on soluble BCMA level. And while they used two dose level, 50 and 200 milligram, they clearly showed that those with higher soluble BCMA, over 400 nanogram per ml, have lower responses. So my question was to the presenter, like, why don't we use then dose adapted response based on soluble BCMA? And clearly, since your dosing is an NTT dose, so why in some of the patient have much higher soluble BCMA increase the dose of the bispecific antibody? And Josh, you may have some experience. You probably do have with this.
Yes, Josh, please.
So I can't give that quite answer, because you're right that Linvo has been dosed up to 800 milligrams, which is well above the target dose, although the number of patients treated with the target dose is somewhat smaller at the moment, so a little hard to say. But I will completely agree with Nizar about the bulk, because the thing that was always surprising to me is, yes, soluble BCMA predicts for worse response to BCMA therapies. It also predicts for worse response to GPRC5D and FCRH5. And there are some great recent papers looking at this, that, part of this, exactly as Nizar was talking about, is just this too much bulk simply to get to. But it's interesting that it predicts for worse outcomes kind of across all the three main targets we've been speaking of.
By the way, guys, apologies. You may see me a little bit distracted at some point, because I'm also trying to answer directly some, I would say, more personal questions from the audience about specific clinical cases, because obviously in this panel discussion, we cannot answer specific, give like second or third opinion, but I'm sure if you reach out to the experts, they will be more than happy to answer. So let me handle now, because we alluded a lot to the issue of infections, and one of the keywords for everybody is T-cell exhaustion. So while waiting to the magic drug that would allow us to avoid T-cell exhaustion, and we would love to have this not only with bispecific, but with plenty of things, this immune stimulation. Would you agree, guys, with me, because I've been asked this question and my answer was very simple, that, okay, this risk is here, but it is definitely manageable, because in hematology, we're quite familiar with managing opportunistic infections in highly immunocompromised patients. We didn't wait until we have bispecific to know about invasive aspergillosis, pneumocystosis, toxoplasmosis, viral CMV reactivation, adenovirus. And my gut feeling, it's about very close monitoring, tracking the microorganism, but also the right to prevention. And maybe we were liberal, I would say, in the past, because we didn't have these issues in myeloma. I'd love to hear your thoughts, unless you have like another magic bullet to avoid all of this. At least in our hands, it works when we monitor very closely, we hit hard immediately, but also we try to prevent. Thierry?
You are an allo doctor. So that's I think you should ask ERA anyway, because, okay, I can understand your point, but still, having a fungal infection, having a CMV reactivation is not good news for patients. And especially, I would say, if you treat older patients. So if you say, I will treat older patients, I will need these myeloma drugs, I will need IVIG, I would need strong monitoring of this just to intervene early or something like that. So at the end of the day, this is a treatment burden, which is very high in a way. So we can manage, but managing a pneumocystosis in a transplant patient at the age of 40 years is not managing this kind of complication at the age of 82. And so I would agree and disagree with you, but I would mostly disagree, in fact.
Okay, let's see, Paula, what's your opinion?
No, I mean, I think that you summarize it very well. You know, we need to be proactive. We need to try to establish prophylactic measures, and we need to follow the patients and monitor the patients closely. But different from what we see in the allo stem cell transplant, there is no a time during the treatment we can say, okay, now it's done. So patient has recovered immunity and we can stop monitoring CNV, we can stop, IVIG or whatsoever. So I think that this is the difficult part of that, so that we need to be aware. Also, I think that we need not to frighten people out, so these are very potent drugs from an efficacy point of view that will probably change the way we treat myeloma, but this other side is that it comes with a significant toxicity in terms of infection, particularly for BCMA bispecifics. So I think that speaks about fixed duration treatment, optimizing the schedule, and not adding too many other drugs on top of the bispecifics, not to further harm more the immune system. And I think it's partly explained by T-cell exhaustion, but not all explained about T-cell exhaustion, because the signal that we are seeing about GPRC5D and BCMA, particularly in terms of severe query 3-4 infection, is different. So probably the BCMA, the B-cell depletion, also plays a role in the immune suppression. So I think that we need to be cautious. We need to do prophylactic. We need to do IVIG. We need to monitor, but the problem is that we do not know, for example, for CNV, we do not know who to monitor, when to treat preemptively, and when to stop monitoring or treating preemptively, because we are lacking all the information that we do have, for example, for the allogenic stem cell transplant.
Okay, so Thierry wanted me to ask the question to Hira. And I must confess, Thierry, that I visited her hospital a couple of times in the last few years. I think the Juravinsky Hospital in Hamilton. And I can tell you, they monitor very well all the microorganisms, whether allo or outside allo. But interestingly, they are lucky because, as you know, when you go north, there are less fungal infections, but that's another story. So Hira, what are your thoughts? How do you monitor these patients?
Yeah, for sure. No, thank you. I mean, part of it is right now we're monitoring all of these in academic centers, right? So they're young patients on trials on academic centers where every time something's atypical, I call my malignant infectious disease colleagues that are highly specialized in knowing what type of monitoring to do. Eventually, BCMA, T-cell engagers will be bread and butter in myeloma, and they'll all be moved to potentially to community. And so there's a lot of education that I think, again, needs to happen around that. So, even when I have my patients now who are more than a year on the T-cell engagers, and if they get a fever at a community hospital, the instructions are still call us, because again, those sites may not know what to test for. And I would agree with Dr. Fakan, who is always right, that the adherence of some of these prophylactic medications will again add an additional treatment burden, and real world patients are going to be older, are going to have, more trouble understanding all these complex instructions and potentially be treated in the community. So as we roll them out, we'll need a lot of education to a lot of these community settings.
No, I think this is a clear message. It's about education. It's a learning curve. And I think we all remember the story of peripheral neuropathy with bortezomib, cardiovascular events with carfilzomib. And I think, with CAR T cells, when we started in lymphoma, CRS, you're going to kill everybody. But It's becoming now standard of care. Qui.
Hi, thank you. I think everyone said it already. The myeloma patients are not like our allo patients. They're older. They have access problems, and they may not be able to turn up for monitoring. And also they are frailer. So if they do get an opportunistic infection, it may hit them harder, and even if they recover, it will take another 10 years off their life, and they will defunction. But also, with this intensive monitoring, what do we do with the results? Do we know what to do with a rising CMV titer in a patient who is perfectly well? And how do you advise your community physicians? So we actually, when our patients are well, send them back out, and we don't monitor. We don't repeat viral PCRs because it's not clear what you do with them in the face of a perfectly well patient. If patients develop fevers and become unwell, well, that's a different matter. So I think we have to be practical as well in our advice to the community physicians. And Paola's right, these agents will be used out there by jobbing hematologists.
Herman, you wanted to comment on this.
I think what we saw in our patients, I always remember one patient, Thierry, when we also had contact, that was about the AMG 420, and you had this patient who really had transaminases in the thousands, and we were both thinking about what could be the potential reason for this, and it was an adenovirus hepatitis then. So I think we have a combination of severe T cell function, but also humoral immunodeficiencies. And what I always found very intriguing is when we looked in our patients that we treated with blinatumomab now a lot of years ago, we found actually that the IgA level were extremely low for about 1 or 2 years. IgM also for 1 to 2 years. But what we also found is that the IgA levels were down and needing no more measurable, often for more than 4 years. And that might also have an impact on the local immune defense. And that's probably one of the reasons why these patients are so much prone to these upper respiratory tract infections, because they're lacking the local immune response mechanism. So I think and I'm completely with the others, that we really have to better monitor our patients and really develop strategies how we can prevent these infectious complications, that we clearly have to have certain screening and monitoring schemes that we use to prevent these infectious complications. And surely by reducing the application of the bispecific antibodies and having fixed treatment intervals will have a major impact on the T cell function, but we still have other infectious complications in these patients.
Nizar?
I just want to briefly add, at ASCO, it actually was 2 abstracts about the reducing the intensity of treatment or density of treatment, so to Q2 weeks versus weekly, and incidence of infection. Particularly the teclistamab data showed very nicely that the incidence of infection went down from 20% approximately to around 10% when they moved on from twice weekly to once weekly, with the caveat that Paola mentioned earlier. These patients now have responded better. They were overall better patient. That's why they reduced the dose density. But this is encouraging to learn that when you reduce the dose density, overall infection rate is lower. With that comes to caveat, what infection are we talking about? We didn't get the granular data. Is it viral infection, bacterial infection? I suspect it's mostly bacterial infection, because I fully agree with Herman. Our experience has been, even when we're using IVIG, we still seeing CMV viremia. We are still seeing a patient with the especially upper respiratory infection and bladder infection. And what you mentioned, Herman, is very interesting about the IgA, because it seems, and the sinus infection, it seems the cavity infection where IgA is important is, we're still seeing those despite IVIG. So bladder infection, sinus, and URI. So yeah, lots need to be learned, but nevertheless, I want to be completely skeptic, and I leave the audience with a negative flair here. Use of IVIG, prophylactic antibiotics, PJP prophylaxis does definitely help reduce at least bacterial infection.
Okay, so thank you very much. It looks like there is actually some agreement on how to move forward in this. Obviously, we don't know the right answer, but definitely I think we have the tools to try to make it safer and to protect to the best we can the patient. Let me move now for the last 10 minutes or so of this broadcast. It is really fascinating discussion to the CAR T cells, because obviously when you speak about immunotherapy, CAR T cells are on the podium, and here I'd like to congratulate again Dr. Herman Ainsley for his plenary talk at EHA and the subsequent New England Journal of Medicine paper, but also a couple of months before this, I'd like to congratulate again Paula Rodriguez-Otero for the KarMMa-3 trial, also published in the New England Journal of Medicine, also plenary session at EBMT. So it looks like when you get the right trial with some attractive results, you can make it to the plenary. So here I would like, and we have actually a few questions, including from the patient, saying, okay, with the results of the CAR T cells we have, why should I use a bispecific? Shouldn't we go to a single shot CAR T cell and then wait and watch? Who's going to take this one? Maybe the answer is simple, say yes, and then, but the problem is how to find all of these CAR T cells. Josh, you're smiling.
No, I'm smiling only because to me, this is going to be the great flip over the next several years. It's that, bispecifics are given to continuous and CAR T is one and done. But as you've seen in this discussion today, we're all talking about limiting bispecific exposure. And because at the moment, although CAR Ts are getting unbelievable results, they're not curing, so there's a look towards maintenance therapy. So in a few years, the CAR Ts are going to have continuous therapy, and the bispecifics are going to be fixed dose. I think these are all wonderful approaches. I think manufacturing right now for the auto CARs is still 4 to 8 weeks, and some of our patients cannot wait that time. To me, the bigger question will be when we get the auto CARs down to maybe a few days, as the Chinese have presented some of their data in terms of the fast CAR. Will that change our approach? Or exactly as Nizar pointed out previously, are some of these people going to need debulking? Perhaps you debulk with a few cycles of a bispecific before giving a CAR. I think, as Terry pointed out, so many options, hard to figure it all out.
Herman, you wanted to comment on this.
I completely agree. I think what we've seen is that the overall response rate and the CR rate is higher with CAR T cells when compared to bispecific antibodies. But we still have the problem of the production time. And the vein-to-vein time in several of these trials can be beyond 6, 7, 8, 10 weeks. And I completely agree with Joshua. We had several patients that we already did the leukapheresis on and that just didn't make it to the CAR T cell infusion because of a non-controlled multiple myeloma. We had patients with CNS disease, extramedullary disease that was massively progressing, and it just didn't. So I think for a patient who has a rapid evolving disease, I think the bispecific as an off-the-shelf therapy is clearly an advantage. It will be different if we have these CAR T cells either off the shelf with an alloCAR. I'm not so confident about allocars because of the immunogenicity and the problem of rejection. Also, we have to see how these more rapidly generated CAR T cells will actually perform in the clinic. But as long as we don't reduce the production time, the vein-to-vein time, I think clearly there are patients where I would go for the bispecific first and then try to control the disease.
Paula?
Yeah, so I think that one of the good things of moving CAR T earlier in the treatment course is that the bridging options will be much more efficacious, and that is what we've seen in the CARTITUDE-4. No? So if we assume, let's say, that in the experimental arm, in the cilta-cel arm, 60% or so of the patients have responded somehow to the bridging, that is the outcomes in the control arm. That means that for those patients, we can wait. So it's not that pressure to have the CAR Ts available in 6 or 8 weeks, because as long as you are controlling the disease, you can wait, and the patients will receive the CAR T in a much better situation. The safety will be better. So I think that the manufacturing time and the vein-to-vein time is a problem in the advanced stages of the disease, where the options for bridge these patients are limited. But it will be less probably if we have CAR Ts approved in first or second relapse. Also to the, we are always comparing the overall response rate for CAR Ts and bispecific, which is not a fair comparison, because patients with bispecifics go there with the bulky disease. Probably we have also selected some of the patients that have gone to the bispecific because they couldn't wait for the CAR T. So we are not, comparing the same treatments. In CAR T, the patients did receive some sort of bridging therapy. And eventually, if we give the bulking treatment before the bispecifics, and then we use the bispecific, as we were discussing before, as consolidation or intensification strategies, maybe the overall response rate will be also higher. We were discussing before, not the soluble BCMA, how these patients are doing poorly with bispecifics, reflecting also high tumor burden. And yeah, it's not a fair comparison, I would say.
Yeah, no, I think this issue of comparison is coming more and more frequently. And although we are not supposed to do it, but actually we all do it, we try to compare across trials. Because, for instance, you know this very well, both of you, Herman and Paula, although I think 99% of the people believe that CARTITUDE-4 and KarMMa-3 trial are exactly the same. Actually, they are not exactly the same. And there are some key differences there. Of course, the constructs are different. So it's very tempting to go and compare, while actually the devil is always in the details, in my opinion, but doesn't mean at all that, of course, these are huge advances. And obviously, patients are really looking forward to get access to CAR T cells, but of course, accessibility, availability, affordability. These are really the 3 goals that we all as a community should work for. Kui, you would like to add something there?
Thank you. Yes, I'll be quick because I see we're nearly near the time. I think obviously CAR T cells have offer the option of remaining in remission for a long period of time off treatment, and that is a big plus. But the other thing that happens, I think, and there's something being published recently that the CAR T cells do much more than just T cell killing, and I think they have the opportunity to reinvigorate the immune environment and stimulate the environment, so that when you're relapsing after CAR T, your host fitness is probably better than when you're relapsing off bispecifics, when your T cells are exhausted and you're at risk of infections, and you're B cell depleted. But putting that aside, I do think access and availability of product is something that is a problem, is an issue with CAR T cells that is not going to go away. So we will learn how to use bispecific antibodies in a way that will reduce the toxicity and help us deliver them in a more tolerable way. Whereas CAR T cells, well, CAR T cells are CAR T cells. How are we going to learn to use them differently? What we have is what you see is what you get.
Excellent. And I think at the end of the day, we will use both of them. Some of them will be available here and there. And we have a comment from a member of the audience, and I fully agree. We will use whatever is available while waiting for the next drug. So here, maybe a provocative question we had on the chat is, do you believe that CAR T cells will remain forever as a single shot therapy? Because, of course, some of the ongoing trials or planned trials actually are not envisioning CAR T cells as a single shot therapy. They're using also maintenance. So, Hira, what do you think?
I do really love the treatment-free intervals with CAR T, and I know the paradigm in myeloma is continuous, ongoing therapy. CAR-T is a change in that paradigm. I do wonder for a subset of population, it will continue to be treatment-free interval, whether there'll be a patients that we identify that need continuous, some form of maintenance post-CAR-T, but that there are a subset of patients that we can just do one shot and then they have a PFS of over 30, 35 months, that they do get to enjoy that treatment-free interval. So I do hope that, we're designing, again, we're able to tease out which patients will actually benefit from that maintenance and not just assume that everybody will need it.
Nizar, you wanted to comment on this?
Yeah, no, I fully agree with Hira, but also with what Kui was saying earlier. So now we're learning that CAR T cells and bispecific antibody beyond the direct tumor cell killing by engaging the target antigen, that do induce a memory immune response from bystander T cells, and clearly see phenotypic T cell expanding in these patient population. So what Hira was saying, I'm hoping in the future we'll know, are there some patient where we can see a good anti-myeloma T cell population persisting in these patient blood well beyond the treatment, where we can safely leave them alone and they can maintain their response. It's going to be the key question we have to address in the future. But also maybe the use of CELMoDs or IMiD as a maintenance strategy to allow these clones to persist, specifically if they're anti-myeloma clones.
Excellent, fantastic. And here you are alluding, Nizar, to the fact that this roundtable discussion was focused on immune therapies, but obviously, as you nicely mentioned, there is a lot ongoing when it comes to the next generation IMiDs. Now we call them CELMoDs, to the XPO1 inhibitors, to the peptide drug conjugates, and many even trispecific antibodies. We didn't mention them, but this is really fascinating. It's already 7:30 p.m. or let's say half past the hour, wherever you are, which time zone you are. It has been really an incredible and lovely discussion. Again, I do apologize we were not able to take all the incredible and fascinating questions and combinations and scenarios people are thinking of, but it is clear that I believe we are all moving in the right direction. And now these bispecific antibodies, the CAR T cells, are providing a lot of hope for patients who, in theory, would have been in palliative and supportive care. So I would like to thank the panelists for their contribution. I'd like to thank all of you who attended, who participated, who contributed, who sent private messages. All of them were positive. I'm very grateful to all of you. All the ISCH activities are available on demand. So you need to give us a couple of days, guys, just to edit this and put it in order, and it will be posted on the ISCH website, available to everybody. You don't need to worry about any password with capital letters, special characters, small letters, numbers, whatever. Open access. It is hematology without borders. Thanks to all of you. Wherever you are, thank you very much. Please stay safe and keep well. Take care.
Bye.